Hey, hello,
Hey,
Michael. Welcome to our webinar to discuss EHR interoperability, which I know that you are an expert in. You've been
I do
doing this
okay.
for a long time. Oh, so let me just say, thank you for joining Reassure Workforce Solution for this webinar. At Reassure Workforce Solution, we bridge the gap between cybersecurity and healthcare, delivering innovative solutions that protect patient data and medical devices while ensuring exceptional care through quality, compassionate support. Our vision is to provide unwavering support to healthcare providers, delivering exceptional care and safeguarding patient outcomes through quality, compassionate workforce. At the root of who we are, our passions are patient safety, patient satisfaction, and patient outcomes. Michael, tell us a little bit about
Nice.
you and HRTC technology.
Yes, I'm Michael Rosenthal with HRTC Technology, and we specialize in, yes, all things interoperability and data exchange and sharing patient data. So we're basically, at the forefront of what we do is ensuring that, patient data is basically all the right data is at the clinician's fingertips, at the right time in real time, as real time as possible. And this is all, with the, mission of, improving, care coordination outcomes and, patient safety, efficiency, all those things. Just ultimately, at the end of the day, improving patient outcomes, patient care, patient safety. And in order to do that, you need the most data about any given patient, at your fingertips, speaking for the provider and the clinician at any given time. And we know that data is spread and fragmented amongst many different systems. And so we bring it all together, make it look like one cohesive patient record, and this improves patient outcomes and patient care.
All right, and we're going to get into some of those things in a few moments, but let me tell about who I am because I didn't do that. I am Dr. Sharnita Rice. I am a nurse practitioner by trade. I've been in the healthcare industry for 18 years. I used to work on computers back in the good old days of DOS. So that is who I am. Now I'm the CEO of Reassure Workforce Solutions. And today we're going to get right on into EHR interoperability. So Michael, tell me what exactly is EHR interoperability for those who don't know, and why should it be a strategic priority for hospital executives?
Absolutely. So yeah, as I was saying with, what we do, EHR interoperability, that's the exchange of, patient healthcare data between different systems, sometimes between multiple EHRs, but they're between different healthcare medical diagnostic systems. And what this does is it, increases again the availability of patient data to the clinician, the provider. And the thing is there is so many different pieces of information in healthcare systems and hospitals, all the way down. We could even talk about one hospital. There's so many different pieces of information spread across different systems. There, all that data is not sitting just primarily in your EHR, lab, radiology, pharmacy data, diagnosis data, even billing information. We can go on and on. So what does that mean? That means that as a clinician, when I'm sitting down and interacting with my patient, I can't run to all of those different systems to try to get that information because that's just too much and not efficient. And so what we do is make sure that that data can be shared amongst many systems, primarily the EHR, because that's where most of your treating physicians work out of. But we want to make sure all that relevant data gets shared into the EHR and into other systems. So then no matter where that clinician is within the healthcare workflow or the patient workflow, they have that information at their fingertips. And for your second question as to why it should be a strategic priority for hospitals, It should be a priority because again, it enhances quality, safety, efficiency, and the overall patient experience. So um, you know, and there's many other, benefits as well. Like, we can get into, revenue, of course, as well. You have to, whether you're not for profit or, in the private sector, there has to be operational revenue to keep things flowing that way. And that all is based on the full, journey of the patient, being admitted all the way to discharge.
So what's the difference between simply extracting data and achieving true interoperability across systems and partners?
Absolutely. Great question. So the difference between just say like extracting or exchanging data versus achieving true interoperability is like right now, you and I are interacting, right? So, okay, I could just be saying anything, A, B, C, D, E, F, G, old McDonald had a farm. You can be like, oh, what are you talking about? So I'm sending data from my voice to your ears. But if I'm rambling just garble, that's likened to a system where you can send your system can send my system information, but if I can't do anything with it meaningful, then it's no use, right? So that's an example of extracting data. Now, as far as achieving true interoperability, the difference is with interoperability is that if you're sending me meaningful data, so if you're sending me meaningful data that I can do something that's going to benefit some cause, then that's meaningful. So as we're sitting here having this webinar, this is meaningful data I'm giving to you. That is more of interoperability. So basically, so just to get a little technical with it, not to get too technical with it, it's instead of just sending data from the EHR to another system or vice versa from another system to the EHR, if I can't use that data, so if the mappings aren't good, if the data is not structured, if it's not discrete, if I can't trend and do something with the data to treat the patient, then that's not true interoperability. But if I am able to take that data that we're sharing between systems and using it in a meaningful way to, create some type of positive outcome for the patient, that's interoperability.
Okay. So how does a lack of interoperability impact patient safety, patient outcomes, clinical workflows, quality outcomes at the leadership level?
Oh, absolutely. I mean, those kind of things where, which is still a challenge. We're in modern day, and because of just so many different vendors and different systems out there that do different things, interoperability is always a challenge, if mostly in pretty much any healthcare organization, whether they have all the bells and whistles or not, interoperability is always a challenge. But however, the lack, of interoperability, that can just, lead to different issues with patient safety, with workflows, overall quality of patient care, revenue, patient safety, all these things. Because if that data, again, you're dealing with many different, systems that talk different languages, that do different functions, but all of that, you know, all those systems need to have some type of output that gets to the clinician's fingertips so that he in turn can treat the patient. And if we lack, a lab system unable to send lab results back to an EHR, or an X-ray that can't get back to the EHR in a timely manner, so that the clinician again can view that information and make a, a patient decision, to make a very positive patient decision for the patient, then that lack can wind up costing in, ways, like I said, through you lose revenue, patient safety, things like that. So.
Okay. So you spoke on revenue. So what are the financial and legal risks of fragmented or siloed data systems? And what's the potential return on investments on investing in interoperability upgrades versus maintaining the status quo or getting the interoperability, getting it right? Because we know that.
Absolutely. Absolutely. Yeah. So the financial risks are going to be things like, operational inefficiency. So you'll be dealing with like increased manual work, rework, just the inaccuracies of human error there, which is of course that's, if we're talking financial risk, you're going to lose money, lose revenue. You're going to increase cost again from doing so much Fred Flintstone type going here to this system, this and nothing talks to anything. And then, of course, again, there that leaves huge room for errors and inaccuracies. And of course, that's going to, create poor patient outcomes because then again, the data is not at you. It's all about the data. The data is not at your fingertips. So you may be missing a med. There's a med you don't know that this patient was on because that data didn't flow over, or there was an X-ray or some type of lab test that was performed on this patient, and that data did not flow over into where that clinician can see that data and assess the patient properly. So those are like some examples of the financial risks. And again, you can't even have good vision, strategy and innovation. Again, when you don't know what, you don't have foresight into what your data is doing, analyzing your data. So then, okay, you can't even move ahead because you don't know what are you moving ahead with? Where are you going? You don't know, you don't understand, your data. And so, yeah, so those are some of the financial risks with it. Now, the return on investment for doing this, of course, is going to be, of course, more accurate data. Your workflows and operations are more streamlined. Of course, number one, your patient outcomes are going to be better. And then, things like that, you're going to reduce costs because you're not going to need as much redundant manual, workflows and resources, or just, inefficiencies. You're doing things two and three times when it can be done one time,
Okay.
things like that. Everything can flow smoothly, through a seamless pathway of data movement, right? And you let your integration do its job and then get that data in the right places, automagically very quickly versus being subject to the slow, movement and workflows of humans and human error.
So have you ever gone into a place that has had fragmented integration, like they've already started the project, but the project was not going properly or it was just not completed the right way and they're still having issues? Have you had to go in and fix a problem that was already there that cost the company?
Absolutely.
Okay.
Absolutely. We've seen situations where we come in and there should be maybe a certain set of data. So, like maybe between the EHR and one, let's say a diagnostic system, they scope the project to send, data A and B there, but then they miss data C and D. And so then that causes again missed out information. So then that it's like, okay, we don't see, we can't see, a particular set of medical reports or medical text or certain information not getting to the billing system, the medical records department for billing. All those things, certain, it can be anything, diagnosis codes, it can be simply insurance and insurance information where that's not getting to the appropriate next step or next system to handle that to properly bill for claims. So we've definitely seen these silos. And the biggest thing is with data fragmentation and just loss of data is when healthcare systems tend to go to a new EHR from an old EHR, and then they miss out on carrying certain information over, certain, again, clinical data, a lot of clinical data they may miss. They may not properly assess their they call it master patient index, so like their full patient population, and making sure the right scope of, the patients get from the old EHR to the new HR, and then making sure all of those patients' clinical history is properly carried over, because that information can be spread out amongst many different legacy systems. And if you don't have the right, experience and foresight to go in and, assess those systems, analyze those systems, and make sure you're not only grabbing the right data, but making sure the data is feasible to convert, and then getting it to the new EHR in a format that the clinicians can use the data, then you'll wind up basically with fragmented data is the short of it. And that's a few of the many different examples of fragmented data out there that that I've seen walking in on projects.
Okay. Okay. So what current federal regulations and incentives should hospital leaders be actively tracking, like the CMS rules, TEFCA, or 21st Century Cures Act?
Yeah, basically, and those are a few examples. Basically, all of those. It is very imperative. These different organizations, CMS especially, they want you to follow their regulations. They incentivize you to follow their those regulations. And then, yes, wherever they need to integrate and either push data to CMS or pull data from CMS, they're incentivized to do that. And sometimes even financially, hospitals are incentivized to do that. But this is all, again, centered for patient care, to treat the patients better, to follow all the different standard medical terminology, code sets, all the different, data element, reference data, we can call it, that's needed to understand, what the data means and how to process that data, and then how to store that data so you can do something with it. And basically with TEFCA, which I think is the Trusted Exchange Framework and Common Agreement or something like that. So that's basically kind of like an information highway platform. So it's like a highway platform where it's a set of standards to where basically data from all various healthcare organizations can kind of push their data there. They can follow those standards, and then facilitate data sharing. And so it's just like a framework that, hey, if you want to be part of this data sharing initiative, we follow the standard, these rules, these regulations. And so it assists in having a kind of a platform of rules that everybody can follow and subscribe to, and then enable, patient data sharing.
Okay. Okay. So we talked about the standards, but which one should hospitals be prioritizing right now? Like, I know it's fire, HL7, the TEFCA. Is there any particular one that hospitals should be prioritizing?
Well, the number one most commonly, so HL7, which stands for Health Level 7, you network geeks out there, that's layer 7 of the OSI model. I won't go too deep in there. So HL7, the common versions of HL7 that is used most commonly, I don't care what hospital you go to, they're probably using version 2, a little bit of version 3. And then FHIR is, which stands for Fast Healthcare Interoperability Healthcare Resources, is a newer version of HL7, believe it or not. It's HL7 FHIR. And it's more of a modern open standard, and it's very good. Where HL7 is more episodal and is more common. It's the de facto standard that's been around for what, at least past probably 25, 30 years, easily. Yeah, easily. And so it's more based on that, commonly used within the hospital for events, visits, admissions and that kind of thing. Whereas FHIR allows hospitals that are separate. So, hospital A, hospital B, hospital C, hospital D, they can exchange data using the FHIR standard. So it's a more modern open standard, and is not so proprietary like HL7 version 2 can be. And it's also a standard that more systems, even beyond healthcare systems, they can understand that data format protocol and the data transmission protocol, which is it is developed around the RESTful Web Services framework. Is literally 100% that. It's just it's a healthcare version of RESTful Web Services framework. And the data messages versus, HL7 is sent in HL7 format. The messages are created there, and FHIR is sent in the JSON format, or it can be sent in SOAP as well. But JSON is more commonly used. But the short to answer your question, HL7 version 2 is more common. Fire definitely has emerged and is becoming very, very popular very fast here. And then you have other standards that are commonly used like X12, NCPDP, you got flat files, you got SFTP. Those are you'll guarantee you'll see those in any healthcare organization that you walk into.
Okay. So looking ahead 3 to 5 years from now, how will emerging technologies like AI, Fire, R5, and cloud native solutions change our interoperability strategy, and how should we prepare now?
Yeah, absolutely. So AI is going to do for anything, not even just integration, anything that has been great and improved and especially automated. I can remember doing so much automation when I was a computer operator. AI is going to significantly change that and improve that because it's going to make integration more seamless. It's going to be able to be like a type of quick on your feet type of thinker. And everything that's great about interoperability now, it's going to make it better, faster, quicker, more flexible. So anything that is great about interoperability now, AI, because it can do so many algorithms so quickly and, trend the data, figure out the actions, figure out the repetitive things that can save time and make things more efficient. AI is going to be that thing to improve everything great about interoperability right now. And, especially with, again, when the data is sent, if AI can do, different types of, predictive analytics to figure out what the next step is or figure out how to make the data exchange more smoothly, faster, efficient, perform better, reduce costs. That's the short of it without going into a heavy technical conversation. It's going to just significantly improve everything great about interoperability.
Okay. So what's the biggest roadblocks hospitals face when trying to implement interoperable systems, and how have some organizations overcome them?
Yeah, I mean, the biggest box I've seen is like, a lot of the systems are like outdated. Um, They're outdated, not compatible. You can't take advantage of certain um, features, improvements, newer modern technology because a lot of hospitals still have maybe an EHR that it was big stuff 20 years ago, and now the technology is like a dinosaur, and so now you want to bring in something more modern. You want to upgrade and implement more efficient interoperability within the hospital, to improve all things within the clinical workflow and process. And then, okay, you got 3, 4, 5 different systems here where they don't have enough modern technology to be able to take advantage of some of the new savvy technology that can improve patient care. So that is, it's that. And so with the outdated, with them being outdated, that means they're going to have almost 100% of the time, they're going to have interoperability challenges. Their interfaces don't do X, Y, or Z to talk to your cool new system. But we don't support that. We don't support an API. We don't send those fields. We don't send those events. We don't trigger that. All we do is these 2 or 3 cool things that we've been doing for the past 20 years, and we've done nothing else. So now you have to try to figure out how to deal with that, those challenges there. So yeah, it's mainly that, and along with that, that goes along with compatibility, security, having the correct standards, and of course that just increases the challenges, for interoperability.
Okay. So how should hospitals handle EHR vendors to create barriers that, no, how should hospitals handle EHR vendors that create barriers to interoperability, whether through proprietary systems or cost structures?
I'm gonna say it just like this, going through this many times. Do your due diligence, choose your vendors wisely. Make sure the vendors that you choose, if you're doing a new implementation, make sure their features and functionality, their security, their interoperability can play nice with, your workflows in the technology you are trying to implement, along with the technology you are trying to integrate, you know, make sure, because this is a full patient life cycle, and basically all the software and the technology are the tools and resources to to aid in completing that successful patient outcome. So that's just number one. I've seen that a lot, where it's just been a challenge where you got decision makers making, they're making decisions and choosing systems that are not best for the organization, not best for the clinician or the patient, and they're not doing deep enough due diligence. And so then that brings me to, okay, what happens if, okay, somebody made that decision 10 years ago? What do we do now? The system's here. What do we do? Upgrade. Upgrade when necessary. You can do that, and weigh the pros and cons. And if you're even looking at ROI and those kind of things, I almost can guarantee you, if you're dealing with systems that lack interoperability, that means there's a lot of inefficiencies throughout your hospital platform and network. And I'm pretty sure with some improved interoperability, you can recover that revenue somewhere along the way by upgrading to more modern systems that can actually meet the needs and the specs of the modern technology. So yeah.
So how can interoperability improve care coordination across inpatient, outpatient, and specialty care, especially in large and rural healthcare systems?
Oh, absolutely. So especially for the rural healthcare systems, the biggest thing is like, they typically, even this is an issue with the smaller practices as well, they can't afford all the big bells and whistles. They can't afford the 800-pound gorilla. They can't afford the rocket ship. So they wind up going with more cost-effective solutions that's within their budget. And so, a firm like ours can come in and say, okay, hey, you don't have the most top-end EHR that's super, that costs millions of dollars. You don't have the most expensive integration engine. You don't have the most, you don't have the most superstar, IT integration staff, that has all the knowledge. So, what can happen here is that we can take the principles of integration and still, assess, their, full, all their systems, all like a rural hospital systems, and then we can connect the data and make it more efficient between the different systems where there can be, where we can see improvements. So especially, smaller hospitals like that, or rural hospitals, they probably, more likely have a huge data fragmentation issue. And so what that does is that limits their access to information, which can make it very challenging for treating the patient. So improving just, in a rural hospital, coming in and providing some streamlined solutions that can, significantly improve their interoperability. That could be a huge benefit for, error reduction, all the different things that interoperability addresses, better patient outcomes, increased revenue, being more compliant, security and all those things. So.
Okay. And then how can interoperability be used to power predictive analytics, population health, and value-based care initiatives?
Same kind of thing. So using, predictive analytics is huge. So that is, taking the data, capturing the data, and, doing things like data aggregation, data analysis, and just basically, taking the data, knowing what to do with the data, especially for, population health, trying to, assess value-based care, or fee-for-service type care. That's, pretty much what predictive analytics can do. You can take large data sets, perform the analytics on those data sets, and then come to, certain, outcomes with that data, come and take certain conclusions with that data. That's going to significantly improve clinical decision support, especially value-based care, because then organizations can kind of determine what, it can help them define what is value-based care for us. How do we charge for said service? Um, you know, um, Having the insight to the data can be a huge benefit to those types of things, population health, value-based care initiatives, and many other things.
Okay. So if you were advising a hospital CEO today, what would be your top 3 priorities to improve interoperability in the next 12 months?
You. Well, I would say just from experience in doing this, there has to be, everybody has to be on the same page. So I would say share vision. There has to be a governance, framework in place. And then, as I was saying before in the previous questions, definitely investing in the right technologies, the right, softwares and hardwares that can enable the highest level of interoperability. And so that would be like the biggest thing. So, you can't have uh, non-unification. Like everybody in leadership has to be on the same page about where they want to go with their patient care, and then they have to be on the same page about what technologies, you know, would be necessary to achieve that vision and those goals. And then definitely investing in when you're looking at those technologies, making sure you have the right foresight, and you're choosing the right features and functionalities with your technology that will allow the organization to achieve the highest level of interoperability, highest level of patient data sharing, because that again is going to always improve patient care outcomes, coordination, safety. Again, because your data lives in a million different houses, and we say, how do we get into all this data into one museum so we can have it on display? And the clinician's kind of like a tourist, kind of, oh, okay, you got this, you had this episode, you had this visit, okay, well, he can look at all that great information and make sure he's taking care of you, the patient.
So, I have to ask this question. How do you ensure HIPAA compliance and cybersecurity when exchanging data across systems and organizations?
Oh wow. Yeah, great question. And I would say for us, since we're moving that data across the wire, just like freaking billions and trillions of pieces of data moves across the internet and networks, every second. And so what we do follow are, which is the same under HIPAA compliance as well. And it's basically making sure that all the different security protocols are followed. So all the different AES security, just when we're transmitting data across different networks, VPN tunnels, following all the standard encryption protocols for that, which again falls under the HIPAA umbrella. And all the policies, procedures, for you HIPAA. So data privacy the same way, ensuring that data is not falling into the right hands. We're sending this data across the wire, and then unless if you're not an authorized entity trying to access that data, then we need to make sure you stay out of it. And we as a firm, we do pretty well with following those protocols. A lot of times when we're working for the clients, they have policies and procedures in place as well. And security privacy policies in place that we must follow, for the client's organization as well as our own security policies to make sure we're using the highest level of security, using the highest level of security protocols and encryption and all those different things to make sure the patient's data is secure.
So, what are the hidden costs of poor interoperability that many executives don't factor into their business case calculations?
Yeah. So again, human error, human error, wasted time, rework, duplicate work, errors, inaccuracies, inefficiencies, multiple repeating things multiple times when you don't have to, having to employ way more resources than you need to because you don't have seamless digital data exchange. So, you know, huge effect on operational efficiency. That is, the hidden cost is, yeah, of course, that's going to take away from your bottom line, especially if you have systems that are not capturing the right data in the right way, especially when it comes to billing. You're not capturing the correct diagnosis codes. You're not capturing the correct procedure codes. So, with the patient's visits, what type of visit it was. You're not capturing insurance information. All this stuff trickles down all the way down to the claims process. If you want to submit a claim for a hospital visit to get paid, if you're missing crucial information about that visit, missing certain clinical data about that visit, those claims are going to get rejected, which is just going to increase your revenue turnaround time to get paid on those claims. So it can cost you in many different ways for not sending your data to the right systems at the right time accurately.
So you mentioned legacy systems earlier, and we know that a lot of hospitals are still on the legacy systems. So, say for instance, they've been on the legacy systems, they have legacy systems that's 10 or 15 years old. Is it more
Mhm.
cost effective to replace them entirely or invest in integration solutions?
A great question. So I would say this is a very simple answer to this. If just like I was saying earlier, if your legacy system's 10, 15, or even 20 years old, and the latest innovation that it has out was something it did 10 or 15 years ago, it's clearly going to be antiquated technology, and more than likely can't keep up with the needs of, modern day. So I would say if it's that old and they haven't had much innovation since then, and of course doing other analysis, you probably would want to compare that legacy systems to some of the more the EHRs and technology systems that have more modern technology, which is going to take you ahead for innovation and make you more profitable. But there's systems out there that are 10 to 15 years old, but they're very modern. They've been out there a long time, but they're very modern in their technology. And so they're kicking butt out there. And so you have to kind of balance the fine line between what that legacy system costs versus what it costs to maintain support that legacy system versus what revenue it can generate you. So if you have a legacy system that, again, it causes you, for example, dealing with a client right now where they have kind of an antiquated EHR, and since that EHR does not support a lot of modern innovations and modules that can really help the clinicians, radiologists, the nurses, home care. What happened here is they're winding up having to buy a bunch of bolt-on systems, they call you. So what the CHR doesn't do in this lack of technology, we have to buy that separately, and that turns to be very costly. Versus you get a more modern, either whether that system's 10 or 15 years old or not. It could be 10 or 15 years old and the hottest thing out there, or if it's a new system with more modern technology that supports more innovation, that'll help not only, again, with the interoperability, make the interoperability more streamlined, help the providers make, the highest, most effective patient care decisions. And then like it can get to the revenue much quicker, much more efficiently, much more correctly. And you do the math on that and say, hey, I either keep this older system that's very inefficient and it's causing me to spend an extra $100 million on all these bolt-on systems, or I invest into this newer system, which in the beginning may cost me more money up front, but in time, over time, I can get into the black and get a much greater return on my investment. That's where you have to kind of weigh that cost benefit and do that cost benefit analysis and figure it out that way.
Okay. So how do we prioritize which interoperability project to tackle first when everything seems equally urgent?
Yeah, great question. I mean, going from client to client, the priority is going to be what the client says is the priority, even if that shouldn't be the priority. But a lot of what I've seen, um, you know, it's pretty much the, you know, if we come in and we're assessing your projects, if you have something deadline sensitive, whether it should be deadline sensitive or not, that's what they're going to want and say, hey, we've been working on this. This is supposed to only take 12 months and we're on the, 28th month and it has to get done, or we don't get funding for this anymore, or we don't get, said benefit for it. Okay, that can become the priority. In my opinion, the priority should always be what's gonna, give you the highest, again, patient care outcomes, patient safety outcomes. So it's the patient first. So whatever is the most critical that can prevent, a patient adverse event, a patient, safety risk, um, or something that's going to improve patient outcomes, which would in turn, if the patients have those, in the patient experience, if they have those great experiences at your organization, okay, they would want to, not that people want to come visit the hospital like they visit the grocery store, but hey, if I do have to come back, hey, I'm coming to this organization because, they invested into their infrastructure and into their staff and their resources and, you know, um, you know, and it made me have a positive experience, right? So yes, patients should be the number one, but then I would say number one A, of course, is going to be, as at least for the commercial and private sector, it's going to be the revenue based projects. The projects can say, hey, if we complete this project, this is going to yield us an extra 1 million, 2 million, 5 million, 10 million a year, or this is going to save us an extra 10 million a year, 15 million. Okay, because then with more revenue, you can do more things with that again ultimately wind up benefiting the patient because you can invest that back into your infrastructure and make the patient experience better. So
We all like going to the newest and the best thing.
yes, we want the finest of the
Yeah,
finest,
yeah.
right?
So can you explain the four levels of interoperability: foundational, structural, semantics, and organizational, and where most hospitals currently stand?
Yeah, I mean, there's different layers to the for interoperability. So I would say, the most I can say is like, having, like, okay, for like structural interoperability, that's more like the structure of the data. So making sure that's exchanged in a specific format, which is that's around that. We talk about HL7 fire, those kind of things, X12, data mappings, those kind of thing. And so that's just a protocol. This is how we're going to talk. This is the language we're going to use. This is what data we're sending, where, when, why, how, at what time. So that's more structural. And then like for semantic interoperability, that data has to be understood by all systems. So that's making sure all those systems can understand HL7 version 2. Make sure they can understand fire. If you need fire communication, which is HL7, version 5 basically, and you need, all your systems to be able to understand that, so that data can flow seamlessly and get into all those systems. So again, the clinicians can have that data at their fingertips. Then that's where semantic interoperability would need to be achieved and understood. And then, like for organizational interoperability, that's all your policies and agreements, protocols with data sharing, and that's things. So that's the organizational level, and that's whatever they set those policies to be at the organization level. Okay, this is like some organizations may say we are only going to send you from our EHR the minimum necessary. So if there's 10 data elements and that's all your downstream system that we're going to integrate with or do interoperability with, that's all it needs to perform its diagnostic test or perform its said action to be of service to the patient. That's all we're sending. We're not sending any more, right? And we're going to block the rest. Um, some hospitals are okay with broadcasting everything, and then they just tell the system, here, you take what you need and then toss the rest. But that's, of course, going to be case by case per organization, and how they set those policies and agreements up. And so, yeah, that's that, um, so, most hospitals are more at the the foundational instructional side. Oh, and I don't even think I mentioned the foundational side, but that's all about. I'm sorry, yeah, the foundational side is the communication piece of it, and none of the stuff like it doesn't guarantee interoperability, and HL7 is one of the most, or just healthcare interoperability in general is one of the most challenging tasks to take on. So it's kind of hard to guarantee, foundational interoperability communication. But you just work together, you negotiate, with your vendors and trade partners, as they call them, and you do your best to kind of meet in the middle. So yeah, these are kind of like the Bibles. These are kind of like the Ten Commandments, kind of thing. They're just like with HL7. These are kind of like just the set of rules we're going to try to follow and do our best to follow them and see where we wind up, kind of thing. So, but most hospitals, yeah, I'm going to say probably those first three, foundational, structural, and somatic. It's kind of hard to achieve the organizational, um, level, getting there, semantic and organizational. It's a little more challenging. Everybody just don't play nice and always follow the rules. So
Everybody don't play nice in the sandbox, huh?
yeah.
So my final question is, this was a great discussion. It's great, valuable information. But if there was one thing that we did not discuss that you wanted organizations or CEOs of organizations or the decision makers of organizations to know about EHR interoperability, EHR integration, whichever terminology that they want to use, what would that be?
Yeah, if there was one thing I would want them to know, the top most important thing is if you are, if it's your mission to continue to, increase, and enhance patient care, patient safety, clinical outcomes, and even revenue, invest in your interoperability infrastructure. Let us come in HRTC technology, perform an assessment, your full, hospital network and systems platform, and, let us, assess and look at ways that your interoperability can not only be improved current state and where you can have the opportunity to, compact, consolidate, streamline, remove in a lot of cases and replace with much more streamlined solutions. Let us take a look at that and do that. And not only look at that for solving your current interoperability problems, but basically setting you up on a platform to be scalable into the future. Because whether we like it or not, interoperability is only going to continue to improve as these new standards become more streamlined, more simplified, more open. More things can talk to more things. That's going to give the hospital down the street that invested in this technology 5 years, 10 years ago, that's going to give them an edge. That's going to make them more preferable to get treated at. And then that's just going to give them a competitive advantage as far as what they're able to, how they're able to benefit the patients and, again, and then the revenue. So that's the top thing above all. It now is the best time to, do an assessment of your, again, your all of your technology and see where you can improve interoperability now, and, into the future, you'll be set to, again, put your organization and your patients in the best position.
Okay. And if I was an organization looking at this and I wanted to get in touch with HRTC Technology and Michael Rosenthal, how would I do that?
Oh, absolutely. So you can reach me for HRTC Technology at Michael at hrtctechnology.com. That is my email. That's my direct email. You can reach me there, or you can also email us at info at hrtctechnology.com. And if you want to reach us by phone, you can always reach out at 877-884 3670. You can also go to our company LinkedIn and ping me there. And so those are three options there that we have. And yeah, if you have any other questions or concerns or any type of interest in improving your interoperability platform and to continue to enhance your patient care at your organization and grow your organization and make it better, please feel free to reach out. We'd love to help.
All right. Thank you so much, Michael, for joining me and
Absolutely, my pleasure.
the Reassured Workforce Solutions crew in discussing EHR interoperability. And as I said here at Reassured Workforce Solution, we bridge the gap between cybersecurity and healthcare. And our passions are patient safety, patient outcome, and patient satisfaction. We don't just look to partner. We don't just look to make connections, but we look to build relationships and build partnerships. We not only vet everyone who comes in, and we vet them, even if it's a travel assignment or a contract assignment, because patients matter. Patient outcomes make a difference to us here at Reassure Workforce Solutions. So if you're looking for a talent acquisition company to help with your cybersecurity infrastructure or even your healthcare at the bedside, you please feel free to contact myself, Sharnita Rice, or our COO, Nakia Copney, at 1-800-394-1250. Or you can go on our website at reassuredsolutions.com, excuse me. That's reassuredsolutions.com. You could also email us at info@reassuredsolutions.com, or you can hit our LinkedIn page, which is Reassured Workforce Solutions.
Awesome.
And Michael, thank you so much for your time.
Thank you for having me. This was a really great conversation. So again, I appreciate you having me on.
Yes. Okay.
All right. Take care.
All right, you too. Tell
All
your
right.
wife to say hello again.
Will do. All right. Yeah, bye-bye.